Hi again, everyone. We're going to try this again. I'm so sorry about the technical difficulties. So today we're excited to be joined by Dr. Matt Avram. He is the Director of Laser and Cosmetics at Harvard Medical School and Mass General Hospital, where he's also the Director of Laser Education. He's also the incoming president of the American Society for Dermatologic Surgery and past president of the American Society for Laser Medicine and Surgery. And Matt is a wonderful educator. We've actually co-authored a book together, and we speak on a lot of different national societies, and he travels quite a bit in terms of speaking in front of an international audience as well. So we're going to get his perspective on how we're going to reintegrate post-COVID in terms of the evolution of our laser practices moving forward, and how he plans on, or both of us plan on continuing educating in this new world. And then we're going to talk a little bit about some challenging cases and take some questions at the end. So can we invite him to join? All right, we're going to try to talk about this. And there you are. I think we got it now. You want to go through some cases?
Yeah, absolutely.
All right, let's see if I can do this. I'm going to try to pull up some before and afters, and then we can talk about what we did. You want to start with scars, or
sure?
All right, so why don't we pull up a scar? Let's see if this will work. No, that covers. Can we make it smaller or no? Okay. So this is a lady who,
from what I see, it looks really good.
Yeah, she presented. She was undergoing a chemical peel by a doctor in the community, and she subsequently developed obviously a complication, probably as a result of a herpetic infection. Was not properly managed soon enough, and resulted in the scarring that's shown here. I don't know if you can appreciate it. I think I might be covering the after, but she had retraction of her upper lip to the point where she was having trouble putting in her dentures before she came to see us. And so you want to talk about how you would address this, and then I can say what we did for her?
Sure. So first of all, you did a really nice job on that, Paul, and that's great. So we see this. I've seen this with chemical peels, and I've seen it with ablative laser. And essentially what happens is, I get this question a lot. If you see incipient scarring, or if you see scarring, should you wait to see how the patient does? The answer to that is no, and I think that's what Paul's going to say. So I'll tell you what I would do. As soon as I saw the redness and the beginning of a scar here, I would treat with a low fluence, so low energy, low pulse duration, 0.45 milliseconds, 1.5 milliseconds, at least with the V-beam. If you're doing the XLV, gosh, it's been a little while. I think it's 3 milliseconds on the XLV. Doesn't matter, but use a short pulse duration, low energy. When you do scars, you don't want to do high energy. And I will combine that with a fractional laser. Often I'm conservative at first, and I do a non-ablative fractional laser. And if I want to get a little bit more in the way of results, I think the ablative fractional lasers do even better than the non-ablative. And I would get on top of this early. And with the fractional laser, I would do low density. This is the lip, so I may go mid to deeper depth, because the depth isn't an issue. And tell the patient to be patient, but that the one thing I would know for sure is that I would be getting them better.
So that's interesting. So how you would do a combination treatment out of the gates with both pulse dye and vascular specific laser?
I might just start with pulse dye, but for 1 or 2 treatments, and then move to the fractional. But I also, and someone's asking, do you do both lasers in the same session? Yes, I might do 1 or 2 pulse dyes right off. And the thing with the pulse dye is that I might even do every week or 2, which I wouldn't do with the fractional laser. The fractional laser, I do once a month. So I might do a couple of pulse dye lasers and then get into the fractional. But yeah, I would start with the vascular laser at least, and then add the fractional laser within 1 or 2 visits.
Right. So what we did is, I mean, all excellent points. And I think, unfortunately, that this woman, it took 6 months for her to find us, which was.
Yeah, that's different. Yeah.
But, I think our colleagues are getting better in terms of, learning, taking advantage of the new paradigm that has shifted, that earlier intervention is better for scars. And I think your treatment recommendations are dead on, where less is more, doing a vascular specific laser. And then we actually combined this with intralesional Kenalog and 5-fluorouracil. I mean, it was very difficult for her, the pain associated with the treatment. So we did a dental block for patient comfort measures. And then, but that was, this is really before the evolution of fractionated technology. So I was doing a non-ablative device called the smooth beam laser concomitantly, a 1450 diode laser. And then we would do the intralesional Kenalog and 5-fluorouracil. And then we had her, starting 2 or 3 days after treatment, start using silastic gel sheeting. And you know, we were, she did very well.
That's a great result, especially with the smooth beam. That's very impressive. The only other thing we do now is, if we do the ablative laser, and it's hard to tell how thick it is, but if there's any thickness to it, we'll do laser-assisted drug delivery as well, which would just be typically just do put some Kenalog drops on after the ablative laser. To get that with the vascular laser and the smooth beam, and Paul was really one of the early people to work the smooth beam, and actually did a lot of work with Q-switch lasers to help with scars. Paul's really been an expert on scars, and then leading to fractional. That's great work. That was a great case.
All right, so we can go do tattoos, we can do hyperpigmentation, we can do melasma, we can do cafe au lait, rosacea.
Hey, whatever you want.
Let's see. Anybody want to vote out there what they want to see next? Let's see.
I'm just looking for any questions while you do that.
Right.
I mentioned that I would do them at the same session. Okay.
Well, you know, obviously a lot of the technology that we're discussing today. Okay, we just got a melasma, so we'll do that one next. Just so everyone knows, a lot of the technology that we're discussing today originated at Dr. Avram's center there at Harvard. And so it's really great to talk to him. So this particular case, laser for tattoo removal, this particular patient was treated with Picosecond laser, which developed at Harvard as well. You want to talk a little bit about the science behind the technology, and then we can go into specifics on what we did in this case.
Sure, and it looks like people really want to hear about melasma. We'll talk about that very briefly. Picosecond lasers are lasers that are unbelievable technology, and they were developed originally about 10 or 15 years ago, but became commercially available in the last 4 or 5 years at the Wellman Center for Photomedicine. Basically, it is a laser is a single wavelength of energy of light, of photons, and it fires at the target for trillionths of a second. So a picosecond is to a second as a second is to 38,000 years. So the orders of magnitude are phenomenal. The amount of energy that you use is the equivalent, is larger than a nuclear power plant, much larger than the bombs that unfortunately that have been dropped in the past. But it's done for such a short period of time that it's very precise, and particularly with the picosecond lasers, doesn't create a lot of surrounding heat, which is amazing. So that's the technology. So at a specific wavelength, it can get a specific color. At 1064, it'll get black. At 755 or 694, it'll get blue or green. At 532, it'll get red. And I think the picosecond lasers get some laser pigments non-specifically as well. So, and I'll lead into that to ask Paul maybe to comment on whether or not he uses these for melasma. Melasma talk now, just because it seems like that's what people want to hear about. Melasma is very challenging. Points 1, 2, and 3 are stay out of the sun, stay out of the sun, stay out of the sun. If you have a patient who does not stay out of the sun, and that doesn't mean, and you have to talk to patients, because at least here in Boston, people think stay out of the sun means don't go to the beach and stare up at the sun for 3 hours. Staying out of the sun means when you walk down the street, walking on the shaded side, when you drive, being aware that there's light coming in through the window, and the same at your home. So wearing physical blocks, zinc, titanium, wearing those to protect you against the sun, staying in the shade, staying out of the sun, not just wearing sunscreen and going out for 10 hours on a Saturday. So number 1, 2, and 3 is staying out of the sun. If patients are on contraceptive medications, that may also feed it. So you have to let patients know these things, because any interventions you may do will fail as a result of not doing that. The next order down the list is doing bleaching creams. So you can do hydroquinone, and there's some good hydroquinones out there, different preparations. You can do azelaic acid. There's some other topicals as well. Then the next is you can do combination topical treatments, such as, what's known as Kligman's formula, or Triluma, which is a combination of a steroid, a retinoid, and the bleaching cream, the hydroquinone. So that takes you, and the other thing that's crucial, at least here in Boston, is the time of the year. And I like making this point, and if we weren't going through a pandemic, I'd probably be doing a post about this. Right now it is April the 24th. I don't even know what day it is because of this,
That's
but
right.
yeah, it's 42 degrees out and drizzling in Boston. But let's say it was sunny today and it's 48 degrees. It feels like it's very cold, but the sun is just as strong as it is in the middle of August right now. So this is the time of year where if you treat people with melasma, they haven't been in the sun too much the last few months, so they're not doing that badly. You treat them, they come back and see you in June and July, and they're much worse. And they're going to think that the laser did it, and the laser might have contributed to it, but just as likely what contributed to it is that they've been out in the sun and they didn't realize it. So treating people, at least here in the Northeast, we have an advantage, which is you can treat people in the fall, they'll be in less sun. So the time of year makes a difference. Next order, I'm going down the line here, Paul, and cut me off when I'm talking too much. The next thing would be light chemical peels, not deep chemical peels where you're going to the papillary dermis and having a week of downtime. We do, glycolic peels, salicylic acid peels in combination with the topicals. If they're recalcitrant after those things, and again, if it's in the fall, we can start looking at laser therapies, but they are not the top couple things that we do. And there are different ways of practicing about this. And I tend to be more on the conservative side about this. So you may get two different perspectives here. But if I were to do lasers, some of the things that you can do is there's some very low density, light 1927 nanometer devices, such as the Fractional Dual, the Laze MD, and you can combine that with the bleaching creams. One treatment that we do is the Laze MD actually has a little thing that shakes up topical tranexamic acid, which is a vascular medication for clots, but it actually works for melasma as well, at least as an oral preparation. And we do that as like a topical drug delivery after the treatment. Whether or not that does anything 2 days after the treatment, who knows? And then in terms of other lasers, you can do very light IPL. I would do that very cautiously. You can do fractional lasers. And I saw a question about 530 to the fractionated picosecond lasers. There are definitely people doing that and seeing some success with that. We've done a little bit of that. Finally, the last thing I would say, and then I'll get Paul's perspective on some of the laser stuff. So I do think the pico, the pico toning, it's not like the way you treat brown spots. This is like the question asked, the fractionated pico, that's very low energy, doing thousands of pulses over a period of 10 to 15 minutes, very low energy, no downtime. The last thing I'm going to mention is oral tranexamic acid. Oral tranexamic acid is a pill, and that can be very successful. And but it's a pill, and there's this slightly increased risk for thrombotic events, but it seems to be pretty modest. But you want to counsel your patients and get some medical background on them. But I would think about doing that, and that's a good thing to do in the summertime when you can't treat them otherwise. Paul, I went way too long. I'm sorry.
No, it was a great answer, and you ended it perfectly, because this patient was actually treated with oral tranexamic acid. So, I agree with everything you said, wow. and a lot of patients who come, as you know, to our centers are usually either they find us or they're referred in by colleagues, and unfortunately, there's practitioners out there who aren't heeding some of the advice that you're doing and rushing into treatment, so to speak, with something like an IPL, where you have the potential to potentially exacerbate this condition. And, you know, what we spend a lot, probably just as much time as you spend answering that question, I'll spend the similar amount of time talking to patients about all the different options, because it is a condition that has multiple components to it. And we talk about the vascular component as well. We talk about the fact that it's heat sensitive. And so we have to be very careful if we're going to be intervening with lasers, doing it, as you said, very, very cautiously. It's interesting, you know, the question about the 532 pico. I agree with exactly what you said. We'll actually turn it all the way down to 0.2, and the patients don't even feel it. And there's really not even an endpoint. So we'll do that typically in combination with the 1064 pico as well. And sometimes we'll do the full beam initially all on the same day. But again, this is something that we're doing in combination with typically oral or topical tranexamic acid, talking about all the measures that you mentioned earlier in terms of sun safety. And then we usually avoid treatment during the summer months as well.
Hey, Paul, because someone asked about this, and you've done some great work on this. Why don't you talk about a potential vascular component to melasma? And I just want to say hi to Aaron Morrissey. Hi, Grant. I want you to talk a little bit about the vascular component of melasma and how you deal with that, because you've been at the forefront of that.
So absolutely, and there's some data that came out of France, and we basically expanded on it. But what we're doing is, and I know you work with the different cameras as well in terms of imaging patients before we do treatments. But with the Visia device, it enables us to do spectrocolorimetry, so we can actually visualize the blood vessels that are underneath some of the pigmentation. And the association that's believed is that there is a process going on, probably related to VEGF, that's where the underlying vessels are stimulating some of the pigment production that's occurring in melasma. And we showed some good cases where you could see these telangiectasias within underlying these lesions of melasma. So our approach was to go very carefully go after treating those telangiectasias. And in our experience, again, when done very carefully, we're finding that it helps to reduce the recurrence, because that's really the biggest issue. You know, we can show all these amazing before and after pictures, but the biggest issue here is what can we do to minimize the recurrence and maintain our results. And we find that adding that to it, whether you want to wait and treat the pigment first and then treat the blood vessels, or if you're experienced enough, you can do the treatment concomitantly, but again, very carefully on the same day, treat both the vascularity as well as the pigment. We'll do that as well. And then, you know, we've also looked at some of the other topical vasoconstrictors. I don't know if you've ever, you know, we've done a little bit of trying Rhofade as well. And we're finding that a lot of our patients with melasma also have a component of rosacea as well. You know, when you really start asking them questions, you'll start hearing, you know, I do have a tendency to turn red easily. And I think there is some overlap that's occurring in these patients that we're, in terms of treating the vascular component, whether it's associated with the melasma or a mild case of rosacea, and then addressing the pigmentation as well. I'm curious to know your thoughts on that.
I mean, I've seen it, and I think it's a subtype of patient. So there's some patients, if where doing the vascular component of it, I think literally is, I think, you know, I'm not sure it's going to do anything, but it's exactly what you said. If you actually look, and this is important, that's why it's important to know about the skin. If you actually look and you see vascularity there, number one, they're going to like having that redness better anyway. But a lot of patients want to try some kind of laser, and to the extent that that's going to help. And I've seen the same thing as you. When I have patients who have that underlying redness or have a telangiectatic component, the melasma seems to, you know, go along for the ride and get better along with the redness. And they just, their texture gets better because there's a non-ablative benefit with the pulse dye laser, and their melasma gets better. So I think it's real. I just don't know if it's the case with every patient. If I have a skin type 5, there's no vascularity, I think you're going to end up hyperpigmenting them, and you're going to make the patient much worse. And the other thing that you said was maintaining your results. And you said something you made a very good point earlier when I kept droning on about melasma. You said, well, I speak to my patients that long. When a melasma patient comes in, that's a long visit for me, no matter what I'm doing, because if a patient doesn't understand the fact that it comes back, that there's no good cure for this, and that this is kind of a maintenance treatment, they're going to be seeing you for a while, and if they don't stay in the sun, it's not going to get better. It's useless for them to have even seen you in the first place.
So, you know, practicing in Houston, which is I don't know if you know this, Houston is the most ethnically diverse city in the country. So I couldn't figure out why I kept getting invited to skin of color panels, and I would be the only Caucasian on the panel. And then I started thinking, okay, well, that it, obviously it's a reflection because of the type of patients that I'm seeing. I mean, we see it, the diversity is incredible. And, you know, to your point, with the first visit they come in, we're just talking. We're not even going to do anything in terms of devices. And this is something that I've learned in my 20 years of treating patients with melasma, is I want to know that the patient is on board and has heard and registered everything that I've said to them in terms of what lifestyle changes they're going to have to make in order for us to be successful with the interventions that we're going to make. And the way we can hold them accountable is when we bring them back, we're taking additional photography and we're assessing whether the patients have any residual tan. It's amazing how many patients come into our office complaining of melasma who have a subtle underlying tan. And you know, that's the worst case scenario in terms of doing any sort of intervention. And so I think all these are very important points in terms of the successful outcomes that we're able to achieve.
And the other thing you need to be careful about, because people will get very upset about melasma and want to sue people. You have to be careful. It's important to be an expert. You have to decide whether or not you're looking at dermatohiliosis or melasma. If you think that you're treating someone's sunspots and it's their melasma and they get worse, they're going to be very angry at you. And it may have nothing to do with the laser settings you did, but it will have everything to do with you misdiagnosing sun damage for melasma or vice versa. And it can be a very subtle diagnosis, particularly in wintertime.
How are you doing on time? Because we're at 12:40, 1:48.
I'm fine. I mean, our audience actually grew, and we had the technical problem. So, I mean, I can do another 10 minutes if you'd like.
So,
sure.
Perfect. So the question from Carolina about is melasma hereditary? I mean, I feel like there is a hereditary component, and it's something that we'll often speak to patients about in terms of that hereditary component can also be a predetermining factor in terms of how they'll respond to oral tranexamic acid. And some of the data that comes out has shown that there are some certain subtypes that are more responsive to tranexamic acid. But the one thing I think is important to mention is that about a third of our patients, you know, that result I showed was obviously amazing, but about a third of the patients who, when they come off the oral tranexamic acid, have a tendency to recur. And so I think, you know, everything you mentioned in terms of topical intervention and then at that point intervening with some of the low-level light is very valuable once we're able to get the patients to a point where the melasma is much better controlled. I mean, it's interesting. We have some patients come in, and I mean, you can see the melasma almost evolving in front of you. It's like, and those are the last patients you want to treat. Those are the patients you want to just calm everything down. You want to suppress the melanocytes. And I think that's where other practitioners get into trouble, where they really want to intervene. They really want to help the patient. But if they intervene too soon, they're making the condition worse.
Yeah, it's very tricky. You know, Vic Ross has this famous line that he says he wants his tombstone to say that he cured melasma. We don't even completely understand what melasma is, even less so how to treat it. Generally speaking, it seems like a lot of the people are gung-ho about treating this, or the people who understand it the least sometimes, because people have a lot of experience, tend to be very, very cautious with this. Right. So my advice would be is to learn as much as you possibly can before you do anything with this, and to counsel your patients heavily. It's very interesting. Paul and I seem to do this very, very similarly. And I would also be highly skeptical of anything or any study that says that it works for melasma, because my experience has been that every time someone comes out with a paper that it works for melasma, we think that's true for about 6 months.
Exactly.
And then it gets sunny out again, and reality happens again, and guess what? It doesn't work so well. And that's happened in my career of 15 years. We've gone through multiple cycles of that.
And I think our colleagues in Asia are a little ahead of us in terms of their use of tranexamic acid, you know, even to the point where it's actually over the counter there. And so I think some of the studies that come out of Asia, you know, perhaps if you look closely, some of those patients may have been taking oral tranexamic acid during the course. So that's important in terms of teasing out what the device is doing and what the treatment's doing.
That's a really good point. I've heard that before too, that some of these studies where you get these great results, read the fine print. And they've been on tranexamic acid. Someone asked about prescribing it on patients with OCPs. You know, you have to think about it. You have to have a conversation with the patient. I tend to be very, very conservative treating lasers generally, and or treating conditions that aren't serious medical conditions. So, you know, anything that can make people more likely to have a vascular problem. Be curious what your thoughts are, Paul. I proceed cautiously.
I wouldn't do it. Wouldn't do it. Can I show a fun Rhinophyma case? These are always fun to do. I don't know if can you see that or no? Just the before.
I saw this on Instagram a few months ago, and I was very impressed. I remember you did a great result, but I can't see it. But
can we move the? You can't move me. Okay. So you want to talk just briefly about what causes of Rhinophyma, how often you're seeing it, who are patients that are susceptible to it, and then we can talk about.
Yeah, I mean, I don't see it very often. This is just you know, a bunch of sebaceous material that causes someone's nose to disfigure and disfigure dramatically. Just as a historical anecdote, W.C. Fields was a famous American comedian who had this. And people sometimes say that their nose makes them, when their nose is red or if it gets bigger, they say look like a drunk, because he would joke about that. And the banker J.P. Morgan had it, and he actually used it to intimidate people when he was doing business with them, because they had this big nose with Rhinophyma, and it used to kind of scare and intimidate people. It's a very disfiguring condition. It gets worse over time. And basically the goal of treating it is to ablate the material that's causing that excess growth. And you can do it in several ways. You can do it, you don't need a laser to do it. You can do it something called loop cautery, which is just heat, and you just kind of cut off those areas. And it's amazing. The nose tends to heal very well as long as you don't go too deep, but this material is usually fairly thick. You can use a blue blade and lop off materials. That won't get you the best result. You can do a blue blade, and you can do a ablative fractional laser. I've done that with good results. And then you can do traditional CO2 laser, which is going to have the most dramatic improvement with one treatment. And I think that's what Paul did, if I remember correctly.
Right.
And we did talk about that.
Yeah, so we did a combination of all those. We did loop electrocautery to kind of debulk the bulbous tissue. And then we used just a 2 millimeter CO2 laser to kind of restore and reshape those areas that were overgrowing. And then we used the ablative fractional resurfacing on top of that to kind of improve pore size and reverse some of the associated sun damage. So, you know, I think the key here is not over treating. You know, you'll see some patients where, and knowing and setting realistic expectations, because if too much, or if this is done too aggressively, it can result in some textural changes, or it can result in some loss of color as well. Can I, because there's a question here that I want to ask you, Matt, are there any new developments in hypopigmented scars, the use of lattice with lasers, your thoughts? And then I'll give you my opinion.
Yeah, hypopigmented scars are a very difficult thing to get better. And we have patients with do well. Sometimes if they're picker scar, like people who pick at their skin, sometimes will get a little bit better. Richard Fitzpatrick, who passed away a few years ago, who, you know, is kind of the king of clinical lasers, mentioned lattice as a combination, and some people have seen good results with that. Another thing you can try is an excimer laser. Unfortunately, an excimer laser typically has a temporary result for hypopigmented scars. So generally speaking, if someone has a white surgical scar or a white thin scar, I feel like the amount that we can improve for them is modest at the very, very best. And just someone asked about which CO2 laser for the Rhinophyma. It doesn't. You can use different CO2 lasers. You can use an erbium laser, to be fair to those companies as well. I don't think that matters. And is Rhinophyma more common in Caucasians, Irish descent? My just from the perspective of what I've seen, I would say that that is the case, but certainly through skin type 3. But hypopigmented scars don't do well. They're extremely challenging. Sometimes if you do an ablative laser, you can get some pigment to come through, but boy, that's really challenging, and I wouldn't promise anyone that.
So we've had some success with ablative fractional resurfacing. I agree it's variable in terms of the results. It's interesting. Joe Wybell has talked about applying Latisse immediately after treatment while you have the increased permeability of the skin. And as long as patients have understand that it's not going to be complete resolution, the majority of times they're happy with the improvement that they see. But I agree, it's very challenging. Should we do one more case, or?
Yeah, let's do one more and then.
Okay, we'll call it.
Yeah, sure.
Let's see.
In terms of someone's asking to do full ablation for Rhinophyma followed by the fractional laser. If you feel like you need to do some fine tuning, you can absolutely do that. But if it gets better, if it's sufficiently better, you won't need to do that. All right? Is that an epidermal nevus or a cafe au lait?
So it's a linear and world pigmented hypermelanosis.
You answer this one first.
So we actually started at a very young age, and I think there's some value in early intervention, and certainly there's a lot of documented literature on the role of early intervention for vascular birthmarks, but I think the same applies for pigmented birthmarks as well, for a variety of reasons. I mean, one, that the skin is thinner. Two, you're having less melanin competing for the laser light. At a patient who's at this age, we can actually do the treatment in the office without the need for additional sedation. The parents typically hold the patient. Obviously, it's very important when treating this to take measures to protect the eye, and we do that with a corneal eye shield. For this patient, we utilize the Q-switch alexandrite laser, which, as you were discussing earlier in terms of the efficacy of this technology for treating tattoos. This is the same technology. Well, this is Q-switch, so this is nanosecond technology. So in terms of, you were mentioning you said 1/1,000,000th of a second for picosecond. This is 1/1,000,000,000th of a second that we use for nanosecond technology. But the point being is that the light is delivered, as Dr. Avram was saying with picosecond, so quickly that it's selective specifically for the pigment. And that's what makes it, when done properly, so safe, is because the energy is being delivered in a way that it's not affecting the surrounding skin. Obviously at Harvard, where Dr. Avram is where the whole concept of what we call selective photothermolysis was developed. But this, I think, is a great example of the differences that we can make in our patients' lives. In terms of early intervention, to reduce the social stigma that this young girl would have otherwise incurred if she had gone to school with a birthmark like this. I still get holiday cards from her every year. She's about 10 years old now, and it's a very rewarding aspect of what we do.
And there's no other treatment for this. You can't cut that out. You can't do serial excision. So the only treatment for these pigmented marks, and luckily this isn't a congenital nevus, doesn't look anything like a congenital nevus, but when you get to those, laser really is not a good treatment. So if you can do something with laser and do it early, it is a life-changing, transformative treatment, as it is here. And yeah, you would do, if you have a Q-switch laser or picosecond laser, either of them are going to work. This was Q-switch. It's, picosecond lasers were developed, I want to say hi from the friends from India and Turkey very quickly. Hey guys. Picosecond lasers were developed mostly for tattoos and less so for pigment. The Q-switch lasers work every bit as well for the pigmented spots as the picosecond lasers do. So I think that's a very good point. You don't need to spend hundreds of thousands of dollars, particularly in the economic climate we are now, to use a picosecond laser to get improvement with this. And someone asked, how early do you start? Paul was just saying, well, you answered early, yeah.
Very early. We'll start, as young as 4 weeks of age. And
right.
the same. Go ahead.
I
No,
was just going to say, for port wine stains, I've treated kids who are a couple weeks old. I mean,
right.
and it's for the reasons that Paul said earlier, and something that Brock Sanderson, over the years working with him, he's told me. He said, as soon as you see one of these, he said, if he saw a port wine stain developing, he would treat it like that day. I mean, you need to be very careful with eye protection. And Paul, maybe you can just talk about that a little bit, about what you did here in this case. But let's remember, you have to be very, very careful treating these. And just in terms of cafe au lait, the smooth border ones don't do as well as the ones with very sharply marginated borders. So you need to take that into consideration. You can do Q-switch or picosecond lasers. But Paul, just for eye safety, just to let the gang know.
Sure. I mean, having had the luxury of training with Roy Geronimo's in New York, where we would see hundreds of newborns with vascular birthmarks, I became very comfortable with inserting eye shields. I mean, and I think it's something where it's interesting when I have visitors coming in. It's something that they're very interested in terms of our technique, and it's something that can be once you it can be done very efficiently and very quickly with the parents holding the child. We put a couple of numbing drops, typically tetracaine eye drops, into the eye, and then we have special eye shields. They're getting harder to find, but they're very small neonate eye shields that fit very nicely, and then that we're able to remove them after the laser treatment. There was a question that was asked about nevus of Oda, and so it's similar concept, but the alexandrite, and you talk about this, Dr. Avram, as well if you want, but so that it's additionally Q-switch technology, but we're using a longer wavelength for nevus of Oda, because in nevus of Oda, we're talking about the pigment is deeper, and so you want to use a longer wavelength of light that's able to go deeper to target the nevus of Oda, because that's something that's going to be more in the mid-dermal layer. And so similar concept in terms of using Q-switch pulse duration, but we're using longer wavelengths of light.
Right. Nevus of Oda is dermal melanin. So the endpoint that you're going to see, rather than epidermal whitening, is going to be dermal whitening. So that's a subtle change that I think if you can see that, then you're really good at what you're doing. And you have to be careful, as with all of these, if a patient has a darker skin phototype 5 or 6, you're not going to use a ruby or an alexandrite. You use a 1064, and you'll do it very carefully. And I would do test spots, because if you get it wrong over someone's face, you're going to have a major problem.
Right.
But they tend to do very well.
All right. Well, this was fun. I hope we can do it again. This was great.
Yeah, it was a lot of fun, and keep up the good work doing your Instagram Live. And I look forward to seeing you as soon as we can.
Absolutely.
AVMs don't respond well to lasers, just for that question. They don't, but that's it. But great speaking with you, Paul, and take care. And as things open up in Houston, let us know what we should be doing here in Boston.
Absolutely. We'll stay in touch.
All right. Take care, buddy.
All right. Bye. Thank you.